history of early satiety present with loss of appetite. There was no significant history of loss of weight. There was history of no no history of well there was
So actually, your voice seems to be breaking up.
per rectum or malleus to swelling bone pain.
Yeah, better.
There is no
Okay, I think we just lost the connection. Just Hashim, could you just call Dr. Anjali?
yes. Can you hear me now?
Yeah, it's better. I think some connection issues are there. Yeah, it's smoother now. Then proceed.
History. She attained menarche at 13 years of age. Menopause at 29 years of age. She's a para to live to full-term normal vaginal deliveries. The first childbirth was at 24 years, second at 26 years of age. And she was breastfed to 2 years. There was no history of OCP use or hormone replacement therapy, no history of any infertility. She consumes a mixed diet. Sleep, bowel, bladder habits were normal. There is no history of smoking or alcohol intake. Coming to the family history, mother had uterine cancer at the age of 52 years and died due to thin disease. Hello, sir, can you hear me?
Yeah, it's audible.
Oh, so it's a 62-year-old parato live to postmenopausal lady presented with complaints of abdominal pain since 3 months and abdominal distension since 2 weeks associated with early satiety and loss of appetite. Coming on to general examination, the ECG performance status was 1, weight was 75 kg, height of 147 centimeter, and BSA of 1.75. Vitals were stable. There was no pallor, icterus, or pedal edema, no generalized lymphadenopathy. Bilateral breast and axilla was normal. Thyroid was also normal. Coming into local examination, after clinic consent and exposing patient from nipples to mid-thigh, patient was examined in supine position on central and everted. Skin or abdomen is no visible pulsations or peristalsis seen. All quadrants moved equally with respiration and hernial orifices were free. On palpation, there was no local rise of temperature. It was 85 centimeter level of umbilicus. No hepatosplenomegaly and no other palpable masses were felt. On percussion, shifting dullness was present. Auscultation, normal bowel sounds was heard. Coming on to the genital examination, the external genitalia appears normal. No palpable inguinal nodes. Urethral orifice appears normal. On perspective examination, vagina and cervix appear healthy, no discharge. On pervaginal examination, there was a hard fixed mass felt in right fornix, non-tender on bimanual palpation. Uterine size could not be assessed due to ascites. On rectal examination, the rectal mucosa was normal, no nodulity in pouch of Douglas, and rectovaginal septum was free. The systemic examination were within normal limits. So, 62-year-old postmenopausal lady presented with complaints of abdominal pain since 3 months and abdominal distension since 2 weeks, associated with early satiety and loss of appetite. On examination, positive findings were abdomen was distended with fullness of flanks, and there was a hard fixed mass felt in right fornix, non-tender on bimanual palpation. The uterus was difficult to assess due to the ascites.
Yeah, Dr. Anjali, can you go back to the slide which was given before that? Yeah, just the slide before. Yeah, hold on, hold on. Next slide. Next slide. Yeah. No, previous slide, previous slide. Only. Yeah, this one. So, what do you think is a provisional diagnosis after examining your patient?
With the patient, considering her age, the postmenopausal status, and then mass in the fornix, most probable diagnosis will be malignancy of the ovary, or second.
Your voice is breaking.
Most ma'am.
Yeah, it was not clear. Can you repeat your statement?
Yes, due to the um, considering the age of the patient, the postmenopausal status, presence of ascites, a mass in the fornix, palpable in the fornix, the most probable diagnosis would be malignancy of the ovary or secondaries to the ovary.
Okay. Which one would you prefer? A primary malignancy of the ovary or other side?
Primary malignancy of the ovary.
Okay. In the history, what all points did you gather? Can you substantiate with your history, in the history? How do you correlate the symptoms with that?
She had
Yeah.
she had abdominal pain and abdominal distension,
Hmm.
and it was of a short duration.
Okay.
And there was a loss of appetite with early satiety.
Hmm. So you have got, you did not get a mass over the abdomen, right? You just got a fornicial mass. Am I correct? And the ascites, correct? So
Yes, ma'am.
what are
Yes,
the,
ma'am.
if
Yes,
not malignancy,
yes,
if
ma'am.
not
Yes, ma'am.
malignancy, if you have to put a DD, apart from epithelial ovarian cancer or ovarian cancer, whatever be the histology wise, what other DDs can you think of?
They can be secondaries to the ovary, next to the ovary, like Krukemberg
Yeah.
tumor.
Yeah.
Then there can be Krukemberg tumors, or it can be unknown primary to the ovary.
Any other benign conditions?
Abdominal tuberculosis, ma'am.
Yeah.
Abdominal tuberculosis.
Yeah. Abdominal TB should be a DD. If not, it comes in the first list if not a malignancy. Okay. So in this case, how do you work up this patient? The patient is in front of you with these findings. She hasn't any investigations done. So how do you work up?
First, baseline investigations I will do, ma'am. Complete blood count, then liver function test, renal function test, complete metabolic profile. Then I will go on with the
priority here.
two.
In this case, do you think that is a priority here?
Diagnostic workup, we can first do tumor marker.
Yeah, whenever asked for the exam, always put these two headings. Otherwise, you should be talking for the patient. It is not a generalized or don't talk from the textbook. So whenever given a patient, what is a symptom and what is that you are going to do first? We obviously are not going to do CBC bio for this patient. So if at all you want to tell that, you can divide the investigations like you are going to do it for the staging purpose and the general workup. Okay. So specific investigations, what all?
Yes, tumor markers, I will do a CA 125.
Why CA?
CA.
Why CA?
Then CA, there can be using some of ovary, CA will be increased to ovary. Also, we can rule out with CA.
Okay, how do you have an idea?
Meds from GI malignancy also can be ruled out.
Yeah, you can have an idea on that when you get two values. But
if the CA 120, if the CA 125 is to CA ratio is more than 25, it favors an ovarian malignancy.
So if this patient goes to a general gynecologist and gets all these done, so when should she refer to you?
If a CA 125,
if imagine your patient is not symptomatic, she has a kind of bloating, and you find there is an adnexal mass, and the CA 125 is 120. So how does she get a reference to you, or does she needs a reference to your side? Go on.
Yes, ma'am. If the CA 125 is to CA ratio is more than 25, and the ultrasound, we will do a ultrasound abdomen with a transvaginal sonogram. If that findings suggest for a for a carcinoma over USG, if we see an ascites, then if there is a solid irregular lesion, multiloculated lesion, with of if there any mets is there or more than 4 papillary projections are there, they will be referred to us.
Okay, you can also calculate the scoring and everything and then decide also. You can, due to the lack of time, you don't go into that. Imagine the patient has a bystander which happens to be her daughter, elder daughter.
Yes.
Yeah, she kinds of a worry. She kinds a bit kind of a worry and ask you, doctor, Can I screen for the same malignancy because this is my mother, so I may have the chance. So how do you counsel her? In other words, some thoughts about screening of ovary, say carcinoma ovary.
There is a chance of BRCA mutation positive in CRA ovary.
What percentage?
10 to 15%. A chance of hereditary risk is there.
Okay.
And if it is BRCA1, the risk of getting ovarian cancer is 50%. And BRCA2, it is 12 to 20%. So if we can counsel them, like if she have at least two relatives with CA ovary, or three successive generations with ovarian cancer or CA uterus or with or a CA colon or if one of the relatives less than 50 years, she should definitely undergo screening.
Who? The patient's bystander.
Yes, ma'am, bystander.
Actually, it is not like that. There is what about screening, general population screening?
In the general population, usually there
Imagine
is
a
ma'am.
Can't hear you. Yeah, can't hear you. Yeah.
We can assess screening by the like CA125. It is not the ideal tool. Like ovarian cancer algorithm, we can see when to screen the patients.
Mm.
Whether it is annually or 3 monthly, or we have to add the transvaginal sonogram also.
Do you advise to all the general population? Every general population?
No, ma'am. We don't advise to all general population. If there is a family history present, we will advise screening with the CA125.
Okay, there is a bit more addition on that. You can go and read. You can read the newer task force guidelines on their updates on the screening. Okay, we'll come back to your patient. You have advised, you have done a tumor markers for your patient. So what next?
Then we have to do imaging.
What is
So
it?
in my institution, usually we go to CT, abdomen, and pelvis.
Okay. So what all?
So in that, we can
what
identify if there is a solid irregular lesion.
Okay. Then
With more than 4 papillary projections, and we can see if it is bilateral, mets are there, ascites, or whether there is omental involvement.
okay.
Then the lymph nodal involvement
Okay.
can also be assessed with imaging.
Okay. So okay. Okay then. So you have your patient. I'll give. Now you do have the findings of this patient CT with you.
Yes,
Define adnexa. Define adnexa. You said there is an adnexal mass, no?
uh,
What is
yes,
adnexa? Define it.
adenasa consists of the ovary, the
Yes.
fallopian tube, the broad
Then?
ligament,
Yeah.
and the vestigial structures and the vestigial structures lying in the broad ligament.
Okay. Connective tissue. Okay. There are 4 structures.
Yes. Yes.
That is a very basic question. So do you have the CT finding? You can just read out.
The CT abdomen done showed large, complex, solid, cystic, predominantly solid mass, 10.2 into 8.
Okay.
Seen in the pelvis towards the right adnexa and crossing the midline and reaching left adnexa.
This is CCT abdomen.
Sol-
Okay.
The solid components show heterogeneous enhancement. It is displacing uterus to the right side with loss of fat play. Right ovary not separately visualized, inferiorly subverting the urinary bladder. It is subverting right distal ureter, however, no upstream hydroureter nephrosis, no obvious infiltration of lateral pelvic walls, maintain fat brains with iliac vessels, perihepatic subcapsular segment 7 deposits noted. Deposits also noted along subdiaphragmatic and falciform ligament. There are multiple omental deposits, largest 7.4 into 5.7 centimeters. The paracolic gutter also seen. Few subcentimeter lymph nodes seen in paraiotic and iotocaval stations. Gross ascites present.
Okay. So what next? Your ascitic fluid cytology, what is it?
Ascitic fluid
Mesothelial,
cytology is
mesothelial.
hyperplasia.
Okay. So what next?
Okay. Since ascitic fluid cytology is showing only mesothelial hyperplasia, we shall proceed with the biopsy from the adnexal mass to confirm the diagnosis and also for IHC.
Okay. So if imagine if the ascitic fluid had been come positive for adenocarcinoma, would you avoid a biopsy?
Yes,
You're happy with
yes,
ascitic
ma'am.
fluid?
Yes, if the ascitic fluid cytology along with the cell block is needed for IHC, plus the CA 125 by CA ratio is more than 25, then we can avoid biopsy.
Okay.
Yes.
Generally, we will not avoid a biopsy if that is do have if there is any contraindication for that. Even if the ascitic fluid has come positive, generally we tend to do a biopsy because all these newer agents have come. You would have to get the the correct histology. Yeah, madam.
Yeah, sorry, I joined in a little late, but I just wanted to also ask that, of course, this patient has large omental deposits. But if the omental deposits were small and your ascitic fluid cytology came inconclusive, where would you biopsy from? Would you biopsy from the mass, or would you want to, biopsy from an omental deposit if there is a doubt?
We can biopsy from the adnexal mass.
The question I'm trying to ask is that, if you are in doubt whether it is a 1A, 1C disease versus a stage 3 disease, meaning extensive omental disease, would you want to biopsy the mass or the biopsy the omental deposit?
Uh,
Okay, let
we
me
have
put
to
it the other
biopsy
way
the
around.
omental
Deposit. Yeah, with the other way around, what I'm trying to ask is if you have only the adnexal mass, would you, if you don't have any diagnosis and you just have the mass and a few peritoneal deposit, would you put in a needle into that mass?
In other words, madam is trying to
Yes, ma'am.
would you discuss with somebody?
Yes, ma'am. I will put in a multidisciplinary tumor board.
Okay, so what I was trying.
Will decide regret.
What will you say? Sorry.
And we can biopsy from the both the adnexal mass and the omental deposits. We have to put this case in a multidisciplinary tumor board, discuss with the gynec oncologist, and we can do a laparoscopy and biopsy from the omental.
Yeah, tell me. Sorry. Hello.
Sorry.
Okay,
Yes,
no,
ma'am. So, ma'am, we can biopsy from the adin. Yes, ma'am. Yes, ma'am.
Yeah, so I can hear you. So the basic question that we were trying to get at is,
Yes,
if you have a doubt that the disease is limited to the ovary, then you would not want to biopsy the ovary because in that case you will upstage the tumor. Of course, if you have disease in the omentum, you have disease in the ovaries, and there is disease all over the place, then you
yes,
can
ma'am.
biopsy from the adnexal mass. Like in this patient, you had disease which was limited to the ovary and which disease which is also there and large deposits are there. So here the disease is already stage 3. So there it would not make a difference whether you biopsy from the omental deposit or from the ovarian mass. But if you have a disease which is largely confined to the ovary, then you don't biopsy that ovarian mass, because in that case you would upstage the tumor. That's what I'm trying to say. Yeah. In that case, you would discuss with your gynec surgeon whether it is feasible for an upfront surgery if there is a high suspicion of malignancy. Okay.
Okay.
Yeah. Yes. I think Dr. Lakshmi, you were discussing regarding the cell block and the ISC. Yeah.
Yeah. Dr. Anjali, tell me briefly about what all IHCs do you expect to be positive in this patient? What is the most histology who might likely to get in this patient's biopsy?
And high grade
Yeah, I agree.
serous
Yes. So
carcinoma.
generally you should have a pathology background also in your mind on your on your IHC report. So what all would be positive? For primary ovary, what all CK7, CK20, how is it?
CK7 is positive and CK20 is negative.
Okay.
And then a PAX8 would be positive.
Okay, that backside denotes what?
It is from epithelial component, serous
From the
component,
no, it is from the Mullerian component.
Mullerian.
Right. Okay. Then other markers, general markers, routine markers.
ER-PR positivity. Then
Okay.
WT1 will be positive.
Okay.
And P53.
Okay. P53. Okay. So you have got a biopsy. What is the biopsy report of this patient? You have the biopsy? Yeah.
High-grade serous carcinoma, cells negative, NAPS negative.
What are the other common histologies as per the WHO classification reason? Where do you think this disease originated from?
Now, concept is from the fimbrial end. Usually, concept is it comes from the fimbrial end. The precursor lesion is the serous tubal intraepithelial carcinoma.
Okay. So when would you denote the primary has started in the ovary? How do you label? When do you label it has come from the ovary?
If we see there is a stick lesion in the fallopian, we have to thoroughly and extensively examine the fimbrial end of the fallopian tube and also the ovary.
Okay, what is that called?
Hello, ma'am.
That sectioning protocol called?
See, ma'am, sectioning and extensively examining
Yeah, what is that?
the fimbrial end. SEM,
CF protocol. Okay. So only if you don't find any stick in anywhere in the fallopian tube and there is nothing in the ovaries and peritoneum only, you will consider this to be primary from the ovary. It is just the 90-degree opposite from whatever we thought before the recent classification. Okay. So this has come at high grade serous. Generally, when to the surgeon refer back to you for your side for further management? So what all specific? So you would be asking the surgeon to do a primary surgery, correct? Yeah, not in this case. Generally, you would ask the opinion whether they can go with a primary surgery. So when do you think the surgeon would send the patient back to you? What is there a
after complete surgical staging, and if the pathology is coming as a high-grade serous carcinoma, there is a need for adjuvant treatment from stage 1 to stage 4.
No, I was asking when does the patient will be referred back to you for NECT?
Uh,
Criteria
after within 25 days, within 20 days after surgery, we should start for adjuvant chemotherapy. Criteria for neoadjuvant chemotherapy. Yes.
Yeah, criteria for neoadjuvant. The surgeon will not open up and send to you for an neoadjuvant chemotherapy. What are those
Okay.
criteria?
According to Leuven's criteria, if the patient is having a poor performance status, a frail patient, medically unfit, then if she's having the involvement of the extra abdominal involvement, then involvement of the root of the mesentery, then if she's having portahepatous involvement, extensive peritoneal disease, diaphragmatic involvement, involvement of the stomach and the pancreas.
Okay. The involvement of the stomach.
Then
You can refine it more. It is not involvement of, yeah, definitely involvement of stomach is a criteria, but still you have a criteria of the small bowel, no? What is that? Because that is the usual thing which happens. Connection gone. Dr. Arun, find her. You find her in the Zoom.
I think there's a little bit of
Connection problems,
it's
I
not-
think, at Dr.
yes.
Anjali.
I'd asked to check, 15 minutes before. Normally we do that before starting. That time it was fine. We'll just be logging in again.
Okay.
Anjali, are you there?
yes, yes, sir.
Anything you can do to make your connection better? It's been a little rocky since the start.
Now is it okay, sir?
Yeah.
Yeah. Okay.
I'll actually lost it.
Is it okay now?
Yeah, yeah. Yeah, madam. We have come with the biopsy of high-grade stress, so we will
Yeah.
distribute the options.
Yeah,
Kindly
yes.
look at it.
Yeah, I heard that. So I had two, three things to say that, you mentioned about this patient having high CA-125 and you did a biopsy and you mentioned that she had high grade serous. So I think while we were discussing, which component of this biopsy do you think suggests for a high grade serous component? You said WT1 positive, P53 mutant.
The cells were
Sorry?
positive. Yes, ma'am. WT1, ma'am.
No. So you have to tell me what does I think Dr. Lakshmi mentioned to you that Paxate is suggestive of a Mullerian marker. Of course, we don't see Paxate here, but Paxate is Mullerian marker. So
Mullerian
anything from the Mullerian origin will be Paxate positive, including cervix, endocervical
ma'am.
thing, ovary, even kidneys are Paxate positive. So Paxate is a Mullerian marker. WT1,
Yes,
so after you know that this is Mullerian, then because it is anyways, you've seen this adnexal mass and it is coming from the ovary, you want to know what type of ovary it is. So you think about serous, right? So that is how that it is a serous carcinoma of the ovaries are WT1 positive. So
Yes.
serous versus
Yes.
non-serous is the thing that you come to know from WT1. Then moving on to, you
Yes, ma'am.
mentioned that high grade. So where does this high grade come from? Which component
Yes,
of
ma'am.
your path report does this high grade?
High grade.
High grade. How do you decide the grade? What is written after WT1?
P53, ma'am.
So
P53
if
is
it is a low
mutant.
grade carcinoma, P53
As-
will be what?
Wild type. Wild type.
Okay, and how do you
It will
decide?
be not.
Suppose there is some outside lab report. Lab tells you P53 is 50 to 60% scattered positive. So is it wild type or is it mutant type? So so I give you 3 reports. Once, because you will get
Yes,
a
ma'am.
lab report which will say different kinds of reports, and you will need to check what kind of you will need to be able to read that report. So I give you 3 situations. One situation that P53 is completely negative. Second situation is
Yes, ma'am.
P53 is 30, 40, 50% scattered
Yes.
positive. And third situation is P53
Yes,
is diffuse more than 80% positive. This is an IHC. So you look at the brown stain on the IHC, right? So it is diffuse more than 80% positive, completely negative, and in between somewhere like 30, 40, 50% positive. So completely negative is what? Mutant or wild?
Wild type, ma'am. Completely
Okay, so
negative wild
no,
type.
so that is the catch-22 situation here. So completely
Okay.
negative and completely positive, both are mutant. Okay. So if it is null type staining, so there you will see a report stating that it is a P53 null type. So of course, if there are no
Okay.
problems with fixation, that is a different situation. But completely negative and completely positive, both are mutant, meaning that diffuse staining and no staining, both are considered as P53 mutant. Okay.
Mutant.
And if it is anywhere like 40-50% intermittent scattering, that is considered as wild type. All right. So this becomes important. I mean, I missed the initial part, so I don't know what is the age of the patient. Sorry, is how old is she? So
62.
62 years.
62 years.
You anyways would expect high grade or low grade?
High grade.
So if this lady was a little like younger age, and where we were debating, whether this is high grade or low grade or even in some older. So there, this P53 becomes important, I mean, and especially for your management changes. So there, P53 would become important, and you need to know whether the P53 is wild or mutant. Okay. Okay. ER negative. And the other thing is the napsine. What is napsine? Why did they do napsine?
That will rule out clear cell carcinoma.
Okay, good.
Clear
Yeah,
cell
good.
carcinoma.
Yeah, good. So that is a clear cell for a clear cell carcinoma. Fine. So and suppose CA125 is 10,000. Your ascitic fluid was inconclusive. Would you still want to do a biopsy, or you think CA125 high is sufficient? No,
No,
CA125.
ma'am. Still, we want to do a biopsy.
Yeah, because it is a sensitive.
Because we need IX.
No, you need a diagnosis, or you think CA125 10,000 is confirmatory of ovarian cancer?
CA125 is not sensitive. It is like it cannot detect. Only 50% of early ovarian cancer it can detect.
So CA125 is sensitive, but it is not specific. So anything
Not
which
specific.
irritates the peritoneum can cause high CA125.
CA125.
Okay. So you would need, so any examples of what all can cause high CA125?
If there is any cirrhosis of the liver, then like there is
Yeah, so anything, even endometriosis, tuberculosis, all of these can also have.
PID.
Yeah, even tuberculosis can give rise to very high CA125 and some atypical cells in your cytology. So you need to be careful if everything is not matching. Okay. So now you have a diagnosis of advanced ovarian cancer, and I think Dr. Lakshmi already discussed with you what are the situations where you would not, you would think of upfront neoadjuvant chemotherapy. So you mainly mentioned about disease-related factors. So what patient-related factors would you want to look at to decide on neoadjuvant versus upfront surgery?
If the patient is frail, having poor performance status, and medically unfit, we will go with neoadjuvant chemotherapy.
So what will you see to see that the patient is medically unfit? You tell your doctor medically unfit, the another your colleague says no, she's medically fit. So on what basis will you say that she is medically unfit? Her ejection fraction is fine. What parameters in the lab will you check? You have some helpline there.
In the examination, no, what do we generally write first? That is a clue to madam's answer.
Ma'am,
Yeah, sorry.
ECG performance status.
Yeah,
echo
ECOG performance status, the albumin of the patients. Many of these patients are, have low albumin, so that is what you can check. So that is what.
The patient is referred back to you, Dr. Anjali, for any CT. So how do you prescribe for chemotherapy? What all would you specifically look for in your lab values before writing onto your chemo chart?
We have to check the complete blood count
What
and the renal.
treatment plan? Just a minute. What would be your treatment plan? How do you define the treatment plan?
For this patient, ma'am, first initially I will go with neoadjuvant chemotherapy with paclitaxel 175 mg per meter square day 1 and carboplatin AUC 6 day 1 of a 3 weekly cycle, about 3 to 4 cycles, followed by interval debulking surgery, and after that followed by adjuvant chemotherapy for 3 cycles.
Okay, so how do you, what all lab values will you specifically look before writing your chemo chart?
We'll look for CBC. Then the renal function test needs to be checked because we are giving carboplatin and paclitaxel. Then we have to check the liver function test.
Okay. Any other values?
And then also, blood sugar levels also has to be checked before, because we are prescribing paclitaxel.
Okay.
Then,
Okay, how do you calculate carboplatin dosing?
carboplatin dose is calculated using the Calvert's formula, that is AUC into GFR plus 25.
Okay.
Then AUC GFR plus 25. So according to that, AUC we will calculate with the formula Cockcroft equation. 140 minus A is into body weight by serum creatinine into 72.
Okay.
And sir, this is a lady. Anything else?
And it's a lady, no? So what correction factor?
Into 0.85.
Okay. So how do you what is the vial strength of carboplatin available?
450 mg.
Paclitaxel? Paclitaxel, what is the strength?
100 mg.
Any other dosings?
125 mg. 30 mg, 50 mg.
I'm not aware of that, such a kind of dosing. Jaya madam,
Sorry.
generally comes in, what is the usual dose? What is the general, like average dose for a female 62 years?
And 100 mg, 100 to 100 mg.
So would prescribe
You're
100
telling dose of paclitaxel is 100 mg?
100 mg or vial strength. You said
175 mg per meter square, day 1, ma'am.
Okay, so what is a vial strength?
Mm, 50 vial strength. One vial contains 50 mg, ma'am.
50 mg, I think, is not prescribed paclitaxel. Sorry, but you don't get 50 mg vial strength.
Yes, ma'am.
Generally, what is the dosing comes? How many paclicarbo have you written? Because generally it is pacli comes
Yes, ma'am.
around a single value.
Uh, um, ma'am,
Have some help from your helpline desk on that
Yeah,
sector.
I'll give you a clue. Generally,
yes,
it is the vial strength comes like in a patient who is generally averagely 1.5 surface area.
ma'am. 300 mg.
300 to 60, 100 and 30. Okay. 100 mg vials are available, yes, and 30. So we have 100, 260, 300. I'm not sure about the 30. So yeah, that is true. But I think she said 50 mg. I'm not sure 50 is available. So that's
Yeah.
what.
Yeah, 100 started being available here, madam, because I was also not sure about 50 had come. Any manufacturers have come with that kind of was not sure.
Yeah, yeah. The 100 is there. So somebody had written on the chat box. So that is what.
Actually, is for how many hours infusion?
3 hours infusion.
Okay, sorry, pre-med. It's a pre-med. We should start discussing the paclicarbo with the pre-med. Right? So what is the pre-med?
Okay. Pre-med, we give injection Emicet 8 mg along with injection dexamethasone 12 mg, means 20 mg in over 30 minutes, plus injection Avil 25 mg, plus injection Randac 150 300 mg. Followed by injection paclitaxel 175 mg per meter square in 100 ml in 500 ml NS, administered using a cordon set 0.22 micrometer over 3 hours. Injection carboplatin AUC 6 we given 5%, 500 ml 5% dextrose over 60 minutes.
So you will give half an hour prior only? Is that your instruct protocol?
No, ma'am. Dexamethasone we have to give the pre-medication has to be given 6 and 12 hours before the chemo protocol.
Dosing?
20 mg of dexamethasone.
Imagine for a patient you have written it, but unfortunately the patient has forgotten to take it, and she'll answer morning 5 o'clock to your chemo ward, and the sister rings you, doctor, this patient has forgotten to take it. What advice would you give her? Shift the schedule, or can you infuse her with some protocols?
We can give dexamethasone 20 mg half an hour before the chemo.
Okay.
Of course, there are different institutional protocols. So for paclitaxel, some of our institutes, we also come down on a lesser dose of dexa to about 8 mg, because each time they keep getting dexa, they get a lot of dexamethasone. So at least a minimum of 8 mg prior to paclitaxel is the minimum which is needed. Okay. And what else will you check? I mean, you mentioned that what is your major concern on your first cycle of paclicarbo? Will you start somebody paclicarbo at 7 o'clock in the evening? Patient didn't get the medicine in the morning. What is the major reaction that you are concerned?
Hypersensitivity infusion related reaction can occur with paclitaxel in the first cycle itself. So we have to start in the morning hours, in the morning working hours.
And when would you expect carboplatin hypersensitivity, early on or later?
Later, ma'am. Usually towards the like cycle.
Why? Why?
Be-
What is the
because this carboplatin it is added up ma'am, yes,
correct?
added up
Go on.
antibodies to the carboplatin in each cycle is added up and it causes sensitivity.
Yeah.
Hypersensitivity.
Okay. So your friend wants to give this paclitaxel and carboplatin weekly. So would you want
Yes,
to give
ma'am.
a weekly cycle or a 3 weekly cycle and any evidence for one way or the other, although it's mainly from the adjuvant data, not so much in the neoadjuvant data. Yeah.
There's only Japanese trial JCOG 316 show that weekly dose test chemo can be given. Paclitaxel 80 mg per meter square was given as day 1, day 8 and day 50 along with carboplatin 86 3 weekly. The other trials were negative trials, ma'am. The Mito 7, the Icon 8, and GLG 262
Yeah.
studies with negative trials.
Okay, so I think that is fine. So basically, you're right. Icon 8 and other negative. So we stick to the standard 3 weekly paclitaxel and carboplatin. Okay. So next, what will you do? 3 cycles, you do a CT scan.
After the 3 cycles, we have to do check the CA125 and also a reassessment scan. So if there is complete response or partial response, we have to proceed with the interval debulking surgery.
What decides interval debulking surgery?
There should be complete response. All extra abdominal disease has to be complete response, and there should not be any progressive disease. Uh, and also the performance status of the patient should have improved and should have been medically fit.
Okay. And what should be the opinion of your surgeon?
We have to proceed with the interval debulking surgery.
Mm.
After
What
the
should be your aim? What should be your aim?
there should be a complete reduction or partial reduction of the masses, and there should not be no extra abdominal mass except for a inguinal node or a retrocaval node which can be resected.
Okay. Can you what will be the what will the surgeon say? I can do this because I can get what?
R0 resection.
Not R0. Terminology is for other sites. Specifically for ovary, what?
There can be a complete resection of all gross disease. It can be possible.
What is the terminology called?
Complete cyto reduction can be possible.
Okay.
I think the word we are trying to get is optimal. Yeah.
Okay.
What is basically the difference between the two? Complete cytoreduction and optimal cytoreduction.
In complete cytoreduction, there is no gross residual tumor. In optimal, there is less than 1 centimeter of residual tumor is there.
I think we have presently come down to no visible disease, no residual.
That is complete cytoreduction. And OCR is, as you said,
less than 1 centimeter.
More than 1 centimeter. No single gross more than 1 centimeter.
Yes,
And no visible disease left behind by the surgeon.
Yeah. And even currently for optimal also we are coming down to no residual diseases, like that's what we are thinking even for optimal. So cross aim is that you should do not leave behind any disease. That's the thing.
So which surgeon had come out with this idea of having an OCR, CCR?
Fagotin.
That is a score. who initially devised all these ideas and put forward these initial terms?
This
Hmm. It was not sugar baker. Somebody had put the chart.
yeah, who found
It starts with G. G. Yeah, it is Griffith. Griffith. Okay. Yeah, madam, please continue.
Yeah, so I just wanted to understand. So this patient, of course, if she has an optimal site reduction, you send it to your surgeon and we'll discuss as to what surgery would you want to do, what all do they want to do. And then we'll come to what do you do if she doesn't respond yet. So currently assuming that your patient, so what percentage of your patients are likely to respond to chemotherapy?
about 80% of patients will respond to chemotherapy.
Okay, so yeah, about 70 to 80 will respond. And what surgery? I mean, a surgeon will do the surgery, but you should know whether the surgeon has done the right surgery or not, and what would you do? Yeah.
We have to do a complete cytoreduction, ma'am.
So what will you do there?
The surgeon has to the steps involved.
What procedure? What procedure would the surgeon do? That was what I'm asking. Like,
Yeah, what structures will they do? Remove what procedure? What incision?
They had to surgeons of like we have to do a interval debulking surgery. We have to the incision is midline laparotomy incision from the sternum to the pubic symphysis. Then, as we enter the abdominal cavity, we have to take peritoneal fluid for examination. And if there is no fluid, 50 ml, 50 cc of normal saline can be instilled and it has to be taken. Then we have to inspect all the areas clockwise from the cecum, ascending colon, right hypochondrium, the liver, then the transverse colon, then the left hypochondrium and the descending colon, the paracolon. Then we have to take peritoneal biopsies from the pelvic organs, the paracolic gutter, and the surface of the diaphragm. Then the surgeon has to do a TH plus BSO. Then they have to remove the grossly visible disease-involved structures and do a frozen section. Then the lymph nodes in this stage, only the grossly involved lymph nodes has to be removed and the omentectomy has to be performed.
So the patient is asking you, doctor, I have disease only in the ovaries, and for that, can you preserve the uterus?
In advanced stage, it is not possible. We have to do a complete staging laparoscopy.
So why couldn't win in that procedure? Many a times you see the uterus will be free only in the pathology report.
Yes,
So
ma'am. Yes, ma'am.
why is CTH done then?
There is a chance.
It is not the cancer comes from the very basic anatomies. So think at that level.
Can be concurrent tumor cells in the endometrium also. There can be occult sticks, serous-tubular endothelial ovarian cancers, and occult mets can be there.
It is basically because they have a common blood supply. So you will have to remove it and that just as you like in the colon, you do the entire area, no? So like that.
Yes,
That is very basic question. Huh?
So the serosa, I mean, you have a lot of serosa over the uterus, so that is why it has to be removed. So basically, okay, in this advanced patient, you will do a total abdominal hysterectomy with a bilateral salpingo oophorectomy. And the most important thing which you didn't mention is the omentectomy.
Yes,
I think that is the main thing. And somebody had asked, do you need to do peritoneal biopsies? I think that is not needed because this, anyways, is a patient with advanced disease. Multiple peritoneal biopsies and cytology is needed only when you are having an early stage disease and you are doubtful about whether or not. I mean, this is an advanced stage, but in this patient with advanced disease, you would need to remove the omentum and do a total abdominal hysterectomy with a valvulus salpingo-oophorectomy. So, okay, so intra, will you also importantly do systematic lymph node dissection for this patient?
no,
Pelvic
ma'am.
lymph
Here
node
we
dissection?
no, ma'am. Here we will only remove the grossly involved nodes. We will not do a systematic lymphadenectomy according to the Lion trial.
Okay, Lion said that, but why would you not do? I mean, in endometrial cancers, you do a lymphadenectomy. In cervical cancers, you do a lymphadenectomy. But why in ovarian cancers? Of course, the trial proved that it is not useful. But otherwise, also that any rationale behind why it was negative?
The overall survival was similar, and there is like more post-operative complications with systematic lymphadenectomy.
Yeah, but what I'm trying to ask is where does ovarian cancer recur? How do you see recurrent ovarian cancers?
Usually in the peritoneum.
Yeah, so basically they would present with ascites, right? So they would present with ascites, peritoneal disease. They don't relapse in the lymph node so much. And where does that brings me to the question, where do ovaries drain into? Paraortic lymph node, pelvic lymph node?
To the paraortic lymph node from the suspensory ligament of ovary to the paraortic, and from the infundibulous pelvic ligament to the internal iliac vessels, to the obturator
Oh,
and internal.
okay, good. That's good. So, okay, so you did the surgery and of course the surgeon has achieved an optimal site reduction. Anything else which can be done during the surgery?
The hyper can also be given for this patient. Hyperthermic intraperitoneal chemotherapy.
So, what is HIPEC?
In HIPEC, ma'am, the cisplatin 100 mg per meter square is administered, and the temperature is 41 to 43 3 degrees Celsius. The peritoneal cavity is circulated with this drug for about 60 to 90 minutes.
Okay, so suppose you are planning to do HIPEC or your surgeon is planning to do HIPEC. So, okay, first tell me that what are the prerequisites for any patient whom you are planning HIPEC? I mean, both from medical perspective and from the surgical perspective, and what is the benefit from HIPEC?
The stage 3 disease can undergo with complete or complete response after the neoadjuvant chemotherapy. They can undergo HIPEC, or in the primary setting also the stage 3 disease and above can undergo HIPEC.
No, so has HIPEC proven a benefit in primary site reduction or in interval debulking surgery?
In interval debulking surgery, it has proven benefit according to the OV HIPEC study.
How much is the benefit?
The recurrent the benefit was about 47 versus 37 months, 10 to 12 months.
It is an
The
overall
recurrence
survival.
rate, yes, ma'am, and the recurrence free survival was also improved.
Okay.
14%
So,
recurrence.
so my basic question is that, importantly, it is not only response to neoadjuvant chemotherapy, but they should have a complete
Response.
have optimal site reduction, and only then you would consider HIPEC. Okay. And of course, you will need to see that you're giving such a high dose of cisplatinum, so they can have the same kind of complications that you would have with high dose cisplatinum. So, somebody, a 70-year-old who has a GFR of 40, you would not consider HIPEC. We've done optimal site reduction for this patient. Yeah, sorry, Dr. Lakshmi.
No, I was just asking, madam, like, why is optimal site erosion so very important in deciding to proceed with HIPEC or not?
Yeah, yes, yeah, this
What
one
is
can say.
Yeah, what is the rationale behind it?
Optimal side reduction is important so that the um, usually this ovarian is a peritoneal disease. So this chemo can chemo drugs we are giving. It can it stays inside the peritoneal cavity and as we decrease the tumor bulk, uh, the perfusion is also more, and the it can reach high drug concentrations in the peritoneal cavities.
So, in a patient with a gross disease left behind, imagine 2 centimeter disease left behind.
Yeah,
In that patient, will HIPEC do good?
no, ma'am.
Why?
Um,
Because we are running short of time. It is basically because all these chemo agents in the peritoneum can go maximum 3 millimeters, maybe 3 to 4 millimeters. So that is why you you select patients only who have got a optimal cytoreduction
okay.
or complete cytoreduction, because you want to treat the microscopic disease, not the gross disease, because it can't penetrate that much. That is a basic thing. That is why we say optimal cytoreduction or CCR is a must, is a surgical prerequisite before proceeding on to HIPEC. Yeah, madam, please continue.
Yeah. So I just wanted to move on one last question on this. One is that if the patient, suppose after neoadjuvant chemotherapy has not, your surgeon still has, CA-125 is still 2000, there's still gross disease left behind. And your surgeon says that, disease at mesentery, root of mesentery, porta hepatis, and surgeon says they can't operate. Now, what will you do?
We have to continue with the chemo cycles up to 6 cycles. We can continue, then we can reassess, or we
Will
can
you
think
stop?
about.
Will you think and, will you pause or, do something and go back to your pathologist or just continue the same chemo? Okay, so
We can
I want
think.
to ask. Sorry?
We can think about adding a bevacizumab.
No. So you're convinced that this is a high-grade serous ovarian cancer. So suppose the patient is very good. CT scan says disease progression. CA-125 is 1000, but patient is ECOG 1. Absolutely well, hale and hearty is coming. So anything that you will think? We discussed a lot about one marker, and she's 30 years old, not 62. Okay. Suppose she's 30 years old,
Yes, ma'am. Yes, ma'am.
very little response to neoadjuvant chemotherapy,
Exactly.
and patient is very good. Disease is not good, but patient is good. Albumin 4. Okay. Will you think of something else? I mean, will you stop and
Other histologies, ma'am. Other histologies.
yeah, we spoke so much about P53. Somebody might read
Yes,
that
ma'am.
interpretation may be varied. You want to rule out a low grade histology, especially
Yes,
patient
ma'am.
is good and disease is not good. And because the treatment management will change completely, low grade will not respond. So if it is actually a low grade tumor, you would want, the same surgical team might say, okay, if it is a low grade, I will try to do a complete cytoreductive surgery and, do. So you have to go back and look and go back to your pathologist and find out what the histology is. Of course, if patient is doing poorly and disease is also poor, but whenever you don't have a response to neoadjuvant chemotherapy, you should always pause, go back, look at if a biopsy has not been done, it is only a cytology and a cell block. You would need to go ahead and repeat a biopsy. If you already have a baseline biopsy, then maybe just go back and look at the biopsy before going ahead. Yeah. Okay. So your patient had a good response and then you did surgery. And then next, how will you plan her further thing? And then with, I think, last 3-4 questions and then we'll close. Yeah.
Ma'am, we had to continue further adjunct chemotherapy, 3 more cycles of carbo and carboplatin. Then we can plan on maintenance therapy.
What maintenance therapy and how do you decide?
Ma'am, if she is We can plan with maintenance therapy with bevacizumab if it was used in the neoadjuvant or with PARP inhibitors.
How will you decide? Patient asks you which one will you choose for me. How do you decide?
We have to do BRCA testing for the patient.
In what sample?
We have to do in germline BRCA testing in blood sample and somatic in a tissue sample.
So this you should have planned in the beginning, right? So you did
Yes,
discuss
yes.
about sending for germline BRCA. So germline
Yes,
BRCA is negative. Next, what test will you order?
HRD, ma'am. Hormonal recombination deficiency. HRD test we can order, ma'am.
On what sample will it be done?
HRD test, ma'am, in tissue sample, ma'am.
Okay. So, so if you have, I mean, of course, you have different HRD scores, both from in-house and outside HRD testing. And of course, if you don't have facility for HRD testing, at least you would want to do a somatic BRCA. So, how will you choose your maintenance strategy based on your BRCA and HRD?
If BRCA is mutated, germline and somatic, we can give maintenance therapy with olaparib for 2 years.
Mhm.
But if BRCA is negative and HRD is positive, we can consider olaparib plus bevacizumab.
Yes, as per the trial, yes, you're right that you can consider olaparib plus bevacizumab. But is there any benefit of giving him any other PARP inhibitors alone in this? What was the fallacy of the Paula-1 trial? I mean, I mean, if it is HRD positive, you have the option of giving olaparib and bevacizumab. But I mean, the main, I think, can you give this patient any other single agent PARP inhibitor?
And niraparib can be tried, but niraparib.
Niraparib is not available in India, or?
Paparib. Paparib.
Yeah, so the other thing is because the main problem with that Paula-1 is that you didn't have a control arm of PARP inhibitor alone. So we do not know how much bevacizumab adds to the HRD. But yes, so if you have only HRD positive, you can give them on a PARP inhibitor alone or a PARP plus Bev. We don't know how much that Bev adds in addition to PARP. So that is the question. If they are BRCA negative, HRD negative, then
We can consider bevacizumab.
okay, but then this is the end of chemo. If you had to use bevacizumab, when would you have wanted to start using that? I mean, do you, in most of the protocols, decide on bevacizumab at the end of chemo or in the beginning?
In the beginning itself. In the
Or at
beginning
least,
itself.
so all patients benefited from bevacizumab. Which patients had an overall survival benefit?
For stage 4 patients. Stage 4 patients.
So I think in today's day and age, we should be able to try to get the BRCA and the HRD early on. And so that, we decide what kind of, if they are BRCA or HRD positive, we don't have to start bevacizumab. But if they are stage 4 disease or they did not have any, I mean, of course, all that bevacizumab trials were adjuvant and they really don't know about the neoadjuvant facility.
I think the time would be
Just
So,
just a single question. You have put the patient, imagine the patient is on maintenance or whichever agent you put, and then they relapse. So, what is the current thought of the current terminology change in this relapse definitions?
We have to classify them if they are platinum sensitive, partially sensitive, platinum resistant or refractory.
Okay.
And accordingly, if it is platinum sensitive, still we have to consider we can re-challenge with carbo.
Mm.
If it is platinum resistant, ma'am, we have to try other drugs like liposomal doxorubicin.
Yeah, platinum refractory anyway, we will not consider her for in the next line platinum. But
Yes,
after that, more than 6 months, it is not very definite that adding carboplatin or adding platinum-based regimens will not give that much of a benefit. So it is a kind of a gray zone now. So generally
Yes,
now you should classify the patient as either platinum eligible or non-eligible. That is how in further meetings this discussion is going on, and further recommendations you will see the terminologies like platinum eligible versus platinum non-eligible. Jaya madam, anything to add on?
No, thank you. I think that was a nice case presentation. Yeah, thank you.
Okay, Dr. Anjali, you present, they will just polish your answers. You can refine these answers for a maximum score. All the best for your exams. Are you second year or third year?
second year, ma'am.
Okay, good.
Thank you, ma'am. Thanks.
Thank you to both our examiners, Dr. Lakshmi and Dr. Jaya, for taking their time out. Thank you, Dr. Anjali. I think for a second year, you did pretty good. So you have one more year of learning waiting. Sorry for this thing. I think there was a little bit of, I think, connection errors, but it got smooth towards the end. So thank you once again for all joining, and see you again next month with a different case. Thank you. Dr. Bobbin, sir?
Yeah, nothing.
Yes, sir.
Good night.
Okay. Thank you and good night to
Thank you.
Thank you.